In this concluding part of the discussion on drugs acting on blood, we'll start by looking at the thrombolytic agents. And these are plasminogen, streptokinase, urokinase, and then the recombinant tissue plasminogen activators, anistreptase, tenecteplase, ateplase, and reteplase. These drugs lyse thrombi by catalyzing the conversion of plasminogen to plasmin. Plasminogen is a single-chain glycoprotein and is converted to plasmin. It causes fibrinolysis. Streptokinase is a 47,000 Dalton protein, which is produced by the beta hemolytic streptococci. Urokinase is synthesized by the kidneys. Reteplase, anistreptase, tenecteplase, and ateplase, all of them are less fibrin specific than the natural tissue plasminogen activator, and they cause what is called a generalized lytic state. These agents are very, very expensive, and they are administered as IV infusion, but they can also be administered intra-arterially, especially in patients with peripheral vascular disease. Uses include pulmonary embolism with hemodynamic instability, in cases of deep venous thrombosis, cases of ascending thrombophlebitis of the iliofemoral vein, then in cases of acute myocardial infarction. They are also indicated in cases of acute ischemic stroke within 3 hours of symptom onset. What are the contraindications to their use? Number 1, dissecting aortic aneurysm, active bleeding, hemorrhagic disorder, acute pericarditis, surgery within 10 days, serious GI bleeding within 3 months, and diastolic blood pressure above 110 millimeter of mercury. Then we come to the antiplatelet drugs. And under the antiplatelet drugs, we have inhibitors of prostaglandin synthesis, and aspirin is the prototype drug in that class. Then we have inhibitors of ADP-induced platelet aggregation, and here we have clopidogrel and ticlopidine. Then the next group are the inhibitors of glycoprotein 2B3A receptors on platelets, and here we have apixaban, tirofiban, eftifibatide. Then we have a fourth category, that is the category of others. And in this fourth category, we have dipyridamole and cilostazol here. So aspirin inhibits production of thromboxane A2 by acetylation of cyclooxygenase 1. It is maximally effective at doses of 50 to 320 milligrams per day, but usually is administered at a dose of 75 milligrams daily, and the main side effect is bleeding, and it should be avoided in patients with an increased risk of GI bleeding. Ticlopidine is a prodrug. It acts by irreversibly blocking platelet ADP receptors, thereby blocking platelet activation. It is used for reduction of risk of thrombotic stroke in patients who have experienced stroke precursors and in patients who have had a completed thrombotic stroke. And the side effects include nausea, vomiting, diarrhea, neutropenia, granulocytosis, and thrombopenia. Then clopidogrel is a prodrug. It's closely related to ticlopidine, And indications for its use are reduction of risk of stroke, myocardial infarction, and death in patients with recent myocardial infarction or stroke. It's also used in established peripheral arterial disease or acute coronary syndrome. The one advantage of clopidogrel is that it can be used in patients in whom aspirin is contraindicated. For example, patients with increased risk of GI bleeding who cannot use aspirin, clopidogrel can be used in such patients, and the dose is also 75 milligram daily. Then the glycoprotein 2B3 inhibitors, these are apixaban, eptifibatide, and tirofiban, and they act by blocking platelet aggregation. They are used in patients with acute coronary syndromes, and the major side effect of these agents is bleeding, and the contraindications are similar to those of other fibrinolytic agents. Vitamin K is an agent that is used in bleeding disorders. It can be administered orally, intramuscularly, intravenously, or subcutaneously. It is used for the treatment of bleeding associated with its deficiency, either from an inadequate intake, absorption, or utilization, or as a result of a vitamin K antagonist. It is routinely administered to all newborns to prevent hemorrhagic disease of the newborn. And plasma fractions, hemophilia A, that is factor due to factor 8 deficiency. Hemophilia B, Christmas disease, is due to factor 9 deficiency. And when factor activity is less than 5 to 10%, spontaneous bleeding will ensue. And in managing these conditions, recombinant clotting factor preparations are preferred for replacement, and the available preparations include omate-P, desmopressin acetate, Autoplex, and Faber. For cryoprecipitate, is a plasma protein fraction that is obtained from whole blood. It is not pre-treated to decrease the risk of viral exposure, and rhesus-negative women in childbearing age should receive only Rh-negative cryoprecipitate. Cryoprecipitate is used for the treatment of deficiencies of fibrinogen, factor VIII deficiency, and von Willebrand disease. Then sometimes you may want to inhibit fibrinolysis, and the agents that are used for inhibition of fibrinolysis include aminocaproic acid, which is a lysine analog that competitively inhibits the interaction of plasmin with fibrin. Absorption after oral administration is rapid, but it can also be administered intravenously, and side effects include hypotension, myopathy, diarrhea, and muscle necrosis. Aminocaproic acid is used as an adjunctive therapy in hemophilia. It is used for control of bleeding induced by fibrolytic agents. It's used for prophylaxis for rebleeding from intracranial aneurysms. Also used for control of post-surgical GI bleeding. Also used for post-prostatectomy bleeding. Can also be used for hemorrhage from the bladder due to radiation and drug-induced cystitis. Then, tranexemic acid is an analog of aminocaproic acid, and mechanism of action and indications are similar as for aminocaproic acid. Then aprotinin is a serine protease inhibitor that inhibits fibrinolysis by free plasmin. It reduces bleeding by as much as 50% in many types of surgery, and is indicated in patients undergoing coronary artery bypass grafting, Adverse drug reactions include increased risk of myocardial infarction, stroke, renal damage, and anaphylaxis. So for patients who have atrial fibrillation, who have placement of mechanical valves in place, and patients on prolonged bed rest, patients who have cancer, and patients who have high-risk surgical procedures, the risk of thromboembolism is high in these individuals. And for these individuals, anticoagulation is required for a lot of these patients. And these patients, heparin or warfarin should be administered in high-risk individuals. Unfractionated heparin, low molecular weight heparin, fondaparinux, all are effective. Then, for patients with established venous thrombosis, treatment should be initiated with unfractionated heparin or low molecular weight heparin for the first 7 days for the first 5 to 7 days, together with warfarin. Then heparin is discontinued once the effect of warfarin is established, and then the warfarin should be continued for additional period of 3 to 6 months. Then activation of platelets is responsible for arterial thrombosis, and antiplatelet drugs are indicated for transient ischemic attacks, stroke, unstable angina, and myocardial infarction. So we stop here. Later we'll take another topic. Thank you.